Good afternoon and welcome. I am Cassidy Avila with the Center for Optimizing Rural Health. Thank you for joining us for this webinar on preventing, mitigating, and responding to violence in the rural hospital setting, presented by Mr. Brendan Riley. Just a couple of announcements before I introduce our speaker. We are recording the webinar, and we will be posting it to our website along with the slides within 48 hours. So you'll receive an email from CORE with a link. And once it's been posted and you get that email, you'll be able to pull down the slides as well as access the recording. If you do have questions during the webinar, we encourage you to go ahead and post them into the chat box. You can send them to everyone, or you can send them to myself, Cassidy Avila, and I would be happy to read that on your behalf at the end of the presentation. So there will be time for Q&A, and you'll be able to unmute and ask your question, or we'll make sure that Mr. Riley addresses any questions that you sent during the presentation through the chat. So now it is my honor to introduce Brendan Riley. Mr. Riley has over 20 years experience working in healthcare security, safety, and emergency preparedness leadership. Prior to joining the team at LaHaye Hospital and Medical Center in 2021, he was the manager of security and chairperson of the Workplace Violence Prevention and Emergency Preparedness Committees at Lowell General Hospital. Mr. Brendan is a certified healthcare protection administrator and is the project leader and subject matter expert for the International Association for Healthcare Security and Safety's Workplace Violence Prevention Certificate Program, having previously served as chairperson of the Boston chapter. Brendan earned both his Master of Science in Healthcare Management and Policy and Bachelor of Science in Criminal Justice and Legal Studies from the University of Massachusetts, Lowell. He is a certified instructor in Crisis Prevention Institute's Nonviolent Crisis Intervention, Management of Aggressive Behavior, Evade Workplace Violence Prevention, ALICE Active Shooter Response, and Rape Aggression Defense for Women. Brendan also teaches free personal safety and self-defense seminars for women, teens, and preteens across Eastern Massachusetts. He is the recipient of many prestigious awards recognizing his commitment to leadership and community service, and is proud to be a White Ribbon Day ambassador for Massachusetts. He resides in Lowell, Massachusetts with his wife, Janina, son, Ryan, and cats, Sandy, Zoe, and Kirby. So welcome, and we're very honored to have you with us today. It's all yours.
Thank you, Cassidy. It's my pleasure to be here on such an important subject matter. And I'll just share with everybody, when my professional association asked me to present at the AHA Rural Healthcare Conference, I had to let them know that I'm city folk. I don't know much about rural hospital environments or critical access hospitals, but I had enough time to prepare for that presentation to reach out to people who do the work in rural communities in the critical access setting, met people all over the country over the past couple months, and really informed my perspective. And I got to be honest with you, I thought we were under-resourced here in the Tertiary Academic Medical Center. We cannot compare to the challenges that are currently faced in the rural setting. So I just want to say a sincere thank you to everybody for the work you do. You do healthcare in its purest form, and you really have a vocation to care for the least favored and those in need in your community. So thank you for having me today. I'm going to talk about this really important subject in kind of two different sections. I'm going to gloss through the beginning. I could give you chapter and verse of how to have a regulatory and accreditation compliant program. And I'm just an email or a phone call away for anybody that needs more resources, and I will get back to you, I promise, if you reach out to me for more information. But I do want to then transition to what I think is the most important message I could ever share with caregivers and healthcare leaders. So for starters, here's a definition. Many of us are probably accredited by the Joint Commission. They came up with this definition in late 2020. We adopted it here in my hospitals as part of our workplace violence prevention policy. I'd recommend you do the same as well. It's pretty comprehensive and definitions vary considerably out there. Just a couple of the data we need to have this subject front of mind for us. We're more likely to be subjected to workplace violence than any other sector. Injuries, non-fatal injuries from workplace violence, 5 times greater than any other workplace, and bedside nurses are at the greatest risk. Reason being, opportunity. They're right at the bedside, close and personal with every population of patient imaginable, including those who are demonstrating active risk behaviors. We have seen an alarming trend over the years through our association about the assault rate for its caregivers, an all-time high in 2021. We think the pandemic definitely had an impact on this. And just a quick refresher for those who are not familiar with the 4 types of workplace violence prevention, they're categorized this way historically. Type 1 is criminal violence. Type 2 is patient or client generated. You can see 85% in that large capture. So definitely the greatest probability. Type 3 is lateral violence, worker versus worker. And type 4 is relationship violence, people who don't work in the facility, but have a relationship with somebody who is an employee coming in and doing harm. So all 4 types are critically important. And some of the highest impact events are type 1, 3, and 4, but probability is we're going to see patient-generated violence, so we have to put so much of our attention in that, but we have to have comprehensive plans for everything. AHA with IHSS came out with this different graphic here. I really think this is a great framework for us to follow. You can see that leadership is at the center. If you want to get anything meaningful done, it really starts here, and here are kind of the buckets that help guide us when we focused on this subject. Here are the foundations of effective workplace violence prevention program. Easy enough, right? You know, you really need all of these things to be effective. And I'm going to highlight some of these during our talk here. And I really like to use accreditation standards to guide this work. It's how I've always done it with my work groups and committees. And starting with the Joint Commission New Elements of Performance Center just for Workplace Violence started being surveyed on January 1st of 2022. And here was a big gap for a lot of places, starting with the leadership standard here. Intentional language here. The program must be led by a designated individual. That's so critically important. It takes a team to get work done, but there has to be that one individual that has ownership. And that was a gap for a lot of places that had shared governance and co-chairs and things like that. So they're really expecting one owner of the program. And these are the critical elements that owner is responsible for, but you must get this work done through a multidisciplinary team. Probably the biggest silver lining of these new requirements was this emphasis on training and education. And again, seldom is Joint Commission this prescriptive. They really defined what every member of the workforce needs to be educated on. It's right in this EP 29 under the HR existing standard. So we need to do all these things. And if you haven't done a gap analysis already, you want to look at your policies and procedures, your education program to make sure that everything identified here is covered. And also this emphasis on what they call a work site analysis annual, specifically for workplace violence prevention program that takes a look at your policy and procedures. It does a walk around of your facility, taking a look at your environmental design and control that's in place, how effective is your training, et cetera. This is such a critical foundational part of the program. We'll talk more about it. And also this importance of reporting. Workplace violence is significantly underreported in healthcare. This was existing EPs that they just added language specific to workplace violence. Historically, this is where people feel they feel most comfortable, enterprise-wide related safety and security reporting systems, capturing all those events. But we do need to be mindful of these requirements. So multidisciplinary effort, it really takes these stakeholders. I think the red is super important. You need people that are working on the line, people that are at the bedside, have the best perspective, a better perspective than anybody working in an office, primarily in leadership, would have. I have had learned from my networking with rural hospital folks. This is often what you call the SFP, the same 5 people. The same 5 people are on every committee that are always coming together to make decisions and work together on process. So identify those key stakeholders and make sure they're at the table focused on this. I have a standalone workplace violence prevention committee that meets monthly. You have to meet regularly. They're not prescriptive on that. Some are still doing it as an arm of the Environmental Care Safety Committee. That's acceptable too. But I do think over time, as OSHA puts more attention to this and federal regulations could potentially be adopted, the more you can do this separate and distinct from other work, probably the better results and the more you'll be on task. That worksite analysis process is so important. And how is Joint Commission going to survey on this? This is right from their stuff. They're going to be looking for documentation of that process. They're not prescriptive on what tool to use. These are probably the 2 most common. I've heard Joint Commission cite these 2 during different talks I've attended. Kaiser Permanente has a security vulnerability assessment, a little bit separate and distinct, but same type of methodology as their hazard vulnerability analysis for the emergency preparedness folks. But also OSHA, the 3148 from back in 2016 has a 10-page checklist right in that document, pages 30 through 40 on the OSHA 3148. And a lot of people that I network with do this, but it's more than just this. And your worksite analysis documentation, you have to include your mitigations. What are you doing based upon your findings to make your environment a safer place? What are your top priorities? Maybe there's something that's cost prohibitive. You've identified it, but you're inching towards a plan. Maybe you have a 3-year plan. Really important. Consider that getting a request from your legal counsel to do this. That would make it protected information, because this could be discoverable. If a violent event comes, you're trying to do the right thing through this documentation, but you probably want to have a close hold on it as well and keep it an internal process. If anybody wants these documents, I have blank copies that I would email to you upon request, no problem. Policy is so foundational here, and it's often a gap. In my new hospital, I've been here 18 months now this week, but we had like 6 or 7 different policies that touched upon workplace violence, but we didn't have that overarching policy that we could link everything else up through. So we created that, and we didn't reinvent the wheel. We went to the resources that are out there. I happen to think that the Oregon Workplace Safety Initiative is the best in the country. Right now, this document is readily available through the Oregon Health Association website. That toolkit gives you a great sample policy that I use personally to guide our work here, but the OSHA 3148 is great. Joint Commission has their compendium resources online, was a bunch of great material. My association, IHSS, came up with our workplace violence prevention bundle, which is a lot of great resources and different policy sources and guidelines as well. Training and education is really foundational. I'm really passionate about this. I sincerely believe this statement here that we expect violence, but it can be avoided and mitigated through preparation. And Archilochus, said this in about 630 BC. It really reigns true today. We know we're putting our people in potentially dangerous situations that will encounter violence. How are we empowering them through education and training? And this is from a Joint Commission perspective. Really where it's at is research and evidence-based education. I recommend people move away from the homegrown type of programs and partner with a vendor that's nationally or internationally renowned, that has done the research. They have evidence-based content. They're well-known. They're going to check every box for compliance, but more importantly, they have an effective way of delivering this education to caregivers. Blended and e-learning options are certainly recommended. It's so hard to get people away from the bedside and their day job, so to speak, to do training. So sometime if you can do an online module is like a prerequisite, then you can really focus when you come together in person on what you have to be in person to actually do effectively. Safe bedside control and restraint and self-defense really comes front of mind for me. But this is what they're surveying on. They're going to interview people. They're going to look at your evidence. So oftentimes doing education online is a great way to have tracking of that in your learning management system of who's completed it and when, organized by individual and departments. And ultimately, support and recovery is so foundational. And certainly we're grateful that accreditors are looking at this. So having trauma support resources there should be many open doors for our caregiver colleagues. If they're impacted by violence on the job, they should have many open doors for support. They should be supported if they choose to report their incident to law enforcement. And I personally think we always need to make sure executive notifications are made for any caregiver. Their functional vice president, whomever they report up to, should know about what happened 100% of the time. In my experience, those leaders will reach out, make a connection. They'll have awareness of what happened, and that really helps heal and let individuals know that this is front of mind for all of us as leaders. It's a top priority of the organization. So really, that's all I wanted to cover really quickly on the compliance side of things. To me, we all need to adopt a mindset of how to protect ourselves from this violence. So I'm really going to do this mindset, skill sets. I want to really, and I sincerely mean this, start with my beliefs. I think healthcare is the most noble profession, especially in the environments that you work in, the purest form of caregiving. You have a vocation for helping those in need and the most vulnerable. And I think, your greatness is rooted in the core values that show up every day. I just presented at nursing orientation earlier today, as I do every other week. And we made a list of what are the values that make us great caregivers, and words like empathy, patience, teamwork, respect, integrity, those keep shining through. And that's what we uphold to do this well. And when we uphold those values, we often keep ourselves safe in the process. I want to talk about the current state of things for workplace violence prevention nationally from my perspective. It starts by understanding what are our patients and their families' expectations of their care in 2023 and beyond. When do they expect this care delivered? Now, immediately. What do they expect the quality of their care to be? Perfect every time. Doesn't matter that she's a 78-year-old lifelong smoker, third complex heart surgery. As she recovers, she's supposed to be as healthy as any 30-year-old. And if she's not in the process, it's your fault as the caregivers. And what do people expect to pay for this perfect care? Should be free. Entitlement for all, right? Doesn't matter how many caregivers have to go into 6 figures worth of student loan debt to qualify these professions, and the millions of dollars we all spend on facilities and state-of-the-art medical equipment and technology. It should be an entitlement. It should be free for everybody. And I know I'm addressing some great caregivers today on the call, and not one of you can deliver perfect, free, and now. That's our reality. And I learned many years ago, the root of all conflict is 2 things: bad past experiences and unmet expectations. Both things are totally out of our control as caregivers, but we really become the lightning rod for emotionally confrontational people in our hospitals and our healthcare facilities when we fail to meet their expectations. And it's really been exacerbated by the pandemic, and it's never been more intense than right now. Take a moment to read some of these headlines on your screen. What we're seeing nowadays is we're seeing a level of distrust and resentment for hospitals and healthcare facilities that we've never seen before. Not unique for healthcare. I think this distrust and resentment's been around for generations for the pharmaceutical industry and insurance payers, but we're seeing that same level now extended to caregivers. And so much of this is totally out of our control, but we need to have an awareness of it. People are paying more for what they perceive to be less quality and longer wait times. And that's all of us across the country. So we have to understand this perspective. And hey, I love healthcare and caregivers, but I agree with her. My cats, they get much better attention and care in the veterinarian than I think I do or my family members do when we enter the healthcare system. So the reality is we see people at their absolute worst. I almost lost my cool this past weekend at the supermarket. They were closed on Easter Sunday, so there was jam-packed. On Saturday, it was just lines 10 deep with carriages to try to get through checkout. And there were like 4 registers closed during this peak time of madness. And I looked around the supermarket and there was a bunch of workers doing other things. I'm thinking, why aren't they at the register? And I'm pacing back and forth. My heart's pounding, sweat is dripping down my back. I felt like I was going to lose it because my expectations over the wait time weren't being met. And that's me. And I'm Joe Cool, when it comes to pressure situations, and I was really seeing red, but fortunately I was able to regulate myself in those moments. Most people cannot do that. They're not disciplined enough when they have that emotional confrontation conjure up, because this is really what's happening during so many of our healthcare encounters. The thinking brain turns off. The emotional brain ends up in the driver's seat, and people cannot regulate, and impacts their behavior. Not everybody who lashes out in a healthcare facility has untreated mental illness or substance use and alcohol on board. It can be regular people just like us that snap when that emotional brain takes over, unmet expectations, the impact of stress, the impact of loss of a loved one, and pain and fear and things like that take over. We have to understand this. Believing that others will react as we would is the single most dangerous myth of intervention. My favorite quote from Gavin de Becker, world-renowned threat assessment specialist. Gift of Fear is a great book. I've read it twice, and I underlined this and I highlighted it. And I've done this so many times, particularly in my early career. This is human nature. What we can all relate to best is our own experience. So very often we try to relate that to the people who are in our care. we start ending up applying a reasonable person standard to the most unreasonable people among us and in their most challenging and difficult moments. So we have to have this awareness never to apply a reasonable person standard, expect people are going to react and process stress and stimuli quite a bit different than we would as professionals. This is real talk. My current view of a lot of the approaches out there that are sustaining nationally that we keep doing over and over and over again. And some reason we think we're going to have different results. And it starts here. You know, I am the biggest opponent rather of the zero tolerance policy. I championed this 20 years ago. This is not new, but this is foundational still to this day. It is such an important part of campaigns. You hear it all the time, the zero tolerance and signs like this list of thou shall not type of behaviors. This is the definition of applying a reasonable person standard to the most unreasonable people among us. The folks on this call today, I don't need to post a sign to tell you that a hospital is a healing environment. You already know that. I don't need to give you a list of thou shall nots. You would not behave this way in a healing environment. And the most aggressive people among us, probably not going to read the sign, but if they do, they might see it as a line in the sand that they're willing to cross. Because ultimately, I'll tell you, every single hospital who's open today in the entire United States of America has experienced verbal harassment and abusive language. Heck, they might even have had threats made already. How many of them were able to uphold zero tolerance? How many are prosecuting for those behaviors? How many patients got handcuffed behind the back today and perp walked out of the healthcare facility? It's not happening. And when you say, but you don't do, you lose all credibility. And this isn't our fault that we can't uphold zero tolerance. It's the justice system. It's totally out of our control. But when you put up these signs, I championed this in 2003. I hung these all over my hospital. 10 years later, I took them all down because violence kept increasing year after year after year. And I made a decision. These are totally ineffective type of messages. If anything, they're adversarial and they're counterproductive. And they let our staff members down as well when we can't uphold these signs and these consequences that we're advertising. And again, it creeps. Look at the last bullet point on the list of thou shall nots. Failure to respond to staff instructions is an intolerable violent behavior. No, it's not. So sometimes we go overboard with this stuff. And ultimately, at the end of the day, how effective are signs? How effective is this sign going to be for your commuters out there, for your ride into work and your ride home after the workday today? So I think we put way too much stock in this. Another thing that's taking hold nationally is this concept of patient code of conduct. This is not a new concept either, but it's really being rolled out again. We're doing the same things over and over again. And again, I can sign up for these things. You know, this is an important message. We have to uphold these values, but how do we message them to people? So we should stand for these things. And our Massachusetts Health and Hospital Association said, let's have a united code of conduct set of principles that we kindly ask that every one of our 71 hospitals adopt these if you go the patient code of conduct route. So they don't deviate too much across different health systems. So I get it. I understand the concept, but we've had major health systems, a system in Massachusetts have over 2 million patients sent this out to every single one of their patients without any pre-explanation. And folks who would never act like this, I think you get this type of response. What the heck is this? Why are you sending this to me? You know, my grocery store, if the supermarket handed me a code of conduct to be a grocery shopper, I'd probably have this type of reaction. So ultimately, these code of conducts do not prevent any violence whatsoever. They may assist with messaging and your ability to punish. But I recommend the alternative approach because signs, I don't want to totally dismiss them. If you stand for these things, you do have to message them to the public in some method. So this is the sign my Workplace Violence Prevention Committee came up with. As you can see, it's not a zero tolerance campaign. There's not a list of thou shall nots, but it's got an important message that we want the public to see and our staff feel supported when we post this message out across our facilities. I am not a code of conduct person. I am a behavior contract person. So if somebody violates these standards that we have up on this attention sign, maybe we follow through with them, the provider, security leader, talking about behavioral expectations moving forward and having to sign off on it. I believe in this in the ambulatory environment, the primary care office, the specialist office, the procedure room. Where these behavior contracts do not work is in your emergency department. You cannot hand this to somebody who's acutely psychotic or under the influence. They're just going to tear it up and throw it in your face. But I've gotten a much further with impacting behavior and getting expected behavior through behavior contracts after somebody's violated these tenets here, as opposed to just a global code of conduct that sometimes can be less than well received by the majority of your patient population. We've got to hold this principle. It's not part of the job. I hear that too often. I will never stand for accepting that violence is part of the job. And here's an image that really resonates. And this is a global phenomenon. This image right here is from Australia and a public service campaign they have. It's never okay. And we all have to champion that. But the reality is these incidents are really on the rise. So what do we do about it? How do we ultimately prevent violence? I'll talk about the justice system later. That's out of our control. But what's in our control is developing personal protection plans for every one of our caregivers, empowering them through education and training and their mindset and their skill sets when they're navigating through people who are emotionally confrontational and might end up being violent. Violence is not part of the job, but is disrespect part of the job. I love surveying caregivers and asking for their response to this. Importantly, language matters. I didn't ask, should disrespect be part of the job? Because universally, the answer to that question is no. I meant it when I said caregiving is the most noble profession. We have a vocation for this. We uphold the best values. So it should not be part of the job, but the reality is disrespect part of the job? I always ask rooms of caregivers who's been disrespected dozens of times on their job. Every single hand goes up. So that tells me this is reality. You know, it's not ideal, but it is part of the job. Violence, no. I stand against that. Disrespect, yes. We see people at their absolute worst. But I'm always in front of people that also have a very different background before they got into healthcare. Many times people on the come up. Background, you remember what your manager always told you was rule number one of the job. Customer's always right? Even if they're wrong, you reread rule number one. The customer's always right in these other fields. And we have a lot more in common in healthcare than sometimes we realize. We are in the human services industry, just like these other folks. I wouldn't say we're apples to apples, but we get a lot in common. But these other different places of work are really great at service recovery. Somebody is getting out of hand over their perceived bad service, 25% off next time. And they're really good at kicking it up to the person in charge. That's a de-escalation strategy that can really lower the temperature. I came up in a security uniform as an officer. I was terribly disrespected and mistreated. People were so nasty to me. But the last 18 years, I've been in a suit and tie. So when my people and our staff nurses get treated this way, and I get called to enter the situation and I walk in looking like this, that same individual now is a perfect lady or gentleman during their encounter with me. So just kicking it up to a person in charge brings the temperature down. These other fields seem to get this more than healthcare. And healthcare, candidly, we're the most noble profession, but we're always right. It's the patients and their families that are always wrong. So sometimes if we kind of change our perspective, it might be a violence prevention strategy. And there's a lot of things that we do that can be relationship damaging, the way we act and how we react. And I'll give you a couple of examples where I've seen a real us versus them mentality. Caregivers, especially versus behavioral health patients. And the image over on the left of the screen there was top story of the national news back in March of 2018 in the city of Baltimore. Behavioral health patient in the emergency department who was cleared medically and cleared by psychiatry and kicked out the door at 3 o'clock in the morning. If you've ever worked in an emergency department, we call it treat and street. It happens in every emergency department in the country. Behavioral health patient is cleared, ready for discharge, out the door. Doesn't matter that they came in kicking and screaming with the police with just the clothes on their back. They have no means to set up their own transportation or pay for it. We don't care. because they're yelling and screaming and manipulating. They're demanding the free ride home at the time of discharge. So the caregivers draw the line in the sand. You're not going to disrespect us or mistreat us. You're out of here. Get out. That's what happened in Baltimore back in March of 2018. It was about 20 degrees out on that winter early morning when this woman was out on the street in just her Johnny gown and hospital slipper socks, but the bars let out and a bunch of young people started audio and video recording her, and it became the top story of the national news outlets. So many people had to resign in disgrace over that situation. The general public did not care how disrespectful or nasty that woman was, nor should they have, because they failed to provide this person with human dignity. And ultimately, if you've got somebody that's ready for discharge, they're yelling and screaming, demanding and manipulating, I give them an Uber Health. I give them a free ride out of there because I want them off my campus immediately. And it's going to protect our reputation. I don't want any of our caregivers to have the local media have a camera and microphone in their face because they did treat and street on a behavioral health patient, but very prevalent across the entire country. Another big one is the use of language like frequent flyers. Let's save that for the airlines. When you start slapping labels on people, I had a caregiver just recently call a hallway through a 9 patients. Hey, there's 9 psychs in the hallway here. You better be ready. You know, imagine how it feels to be labeled that psych. And when you start slapping labels on people, it's very relationship damaging. Words matter. I prefer, oh, this is a patient who's known to us. Much different than the frequent flyer type vernacular. All over the country too, we take cell phones away from people just because they're a behavioral health patient. Doesn't matter if they're totally a cooperative. You're a behavioral health patient, give me a phone. We don't have that standard with medical patients. I think it's pretty discriminatory, and it's also very relationship damaging. I'm a big proponent of a one strike policy, even for behavioral health patients. We're gonna let you use your phone, but if you misuse it, you start audio and video recording us, you start live streaming, you start yelling and screaming at somebody you're talking to over the phone, we take your phone and you don't get it back until you transfer or discharge. That is relationship building. When you just take it because of the status of behavioral health patient, it is definitely relationship damaging, and it's hard to overcome. And there are patients that are controlled and restrained, and there's caregivers that are pummeled and seriously injured just trying to wrestle these phones away when the person hasn't even used it inappropriately yet. So I do think we need to be more thoughtful and our policies and our procedures and our standard operating procedures when it comes to cell phone use, because to me, this is an extension of the human body. You know, if at top of the hour, I said, everybody put your phone in a drawer for my hour talk, everybody would have logged out. So our patients are no different than us. And sometimes we give in. Sometimes it's the caregivers who were overwhelmed by their own stress in these situations and do the equivalent of pouring gasoline on flames when a patient's in crisis. So just something to really be mindful of. Another key concept to me is this, distinction between risk and crisis. As risk managers, which every healthcare leader is, there's so much on our plate. There's so much we need to balance and be prepared for. But we need to put most of our eggs in the crisis basket, the stuff that we know is going to happen. The 4 types of violence, we need plans for all of them, but you need to put most of your effort into patient-generated violence. You still need a plan for criminal violence and lateral violence and relationship violence, but most of your eggs go into that basket for the patient-generated violence. My hypotheses of the current problem in this country, why violence continues to be on the rise, is our focus is way too much on elements of an important program while we disregard the total foundations. So to me, how do we determine these? As risk managers, we know it's all about the likelihood of an event happening and the severity of harm. And what can we do to mitigate both likelihood and severity of harm? And that brings us to kind of the place of what's most in our control? What do we know is going to happen that could have a high impact? And let's really start there. Everything's important, but the foundations are most important. So this is kind of from my perspective, what are the top priorities right now in United States healthcare for workplace violence prevention? These are the 3 biggest efforts I see day in and day out. The 2 bottom ones are not even on my list. The top one is something we need to have a plan for, but I think it's sometimes way too big of a priority, while other things that are mission critical, from my perspective, are often totally ignored. These are really the big three that I think would lead to true violence prevention. Starts at the bedside with physical skills, population-specific de-escalation, and having real professional healthcare security personnel makes such a difference at keeping patients and staff members safe. So let's start with what I consider elements. We need to have plans for these things, but they're not as important as foundations. Any low probability event, it can't have too big a piece of the pie. And we'll start with the active shooter. And this is some stuff I found in some of these full-scale drills that happen. I am the biggest opponent of a full-scale active shooter exercise in a healthcare setting, because the probability is so low. If you've seen the FBI data for a 20-year capture, there were 15 incidents in healthcare over the course of 20 years. So unfortunately, these tragedies have happened, and we had two major ones last year in 2022. Knock on wood, though, most days of this year, there won't be a single United States caregiver that's harmed by a firearm. Most days this year, not one. Unfortunate reality, there may be some days that there's a tragedy and somebody is harmed in a healthcare facility with a firearm, but the overwhelming majority of days this year, not a single US healthcare worker will be harmed. So when it comes to these full-scale exercises, you can read this here. I hear this feedback a lot, that it's more traumatizing than empowering for caregivers. It's always going to be somebody that doesn't know that it's just a drill. And ultimately, the probability is so low, you're far more likely to be struck by lightning than be subjected to an active shooter in a healthcare setting. And also think about, flying. Flying's the safest form of travel, by far and away the lowest probability of the plane going down of all the modes of transportation. But we have our awareness level training for what if something does go sideways on our airplane. What can we do to try to keep ourselves safe? But I don't think anybody would advocate for filling a plane up with smoke and dropping it 10,000 feet to go through that experience and have more of a hands-on feel that's just a training exercise. I'd rather just focus on awareness level. And my active shooter course, and I've done thousands of them literally, focuses on these type of elements that are so important. That gap of time before the help comes, empowering people with options, knowing, making sure they know they're the decision maker, nobody else. The help is not just going to be there instantly. They have to navigate through mental conditioning. What are my options? How could I run, hide, fight? This concept of normalcy bias, where the brain has a funny way of tricking us that this is normal. Even the most abnormal, life-threatening situation, the most stressful situation that you've ever been through that you could never even imagine, the brain often tricks the majority of people to normalizing it and not taking any action. And then the OODA loop, to disrupt the OODA loop, to attack the attacker. These are the major concepts I always focus on with my awareness level training. And ultimately, even though I'm a real opponent of full-scale exercises, I'm the biggest believer in department level, because this is front of mind for our healthcare workforce. Even though it's so low probability, they care about this. They want to know what to do. So giving everybody the same foundational level of training, but then going out there at the department level, all shifts, 7 days a week, and having, through our security service here, some of the department level talks where you apply, run, hide, fight right to the department level and get people thinking about this critically. But what you will not see from me is me running around with an airsoft pistol, firing off rounds or throwing tennis balls at people, saying that's simulated gunfire. I see no value in that. I see a lot of value in talking about this at the awareness level and the department level. Weapons detection is get rich quick right now in our country. There are people spending multi-millions of dollars on equipment and operationalize this, and I understand where they're coming from, but far too often their program looks like what you see on the left. Effective weapons detection only looks like what you see in the airports through TSA. That level of equipment and technology, that level of personnel to operationalize the screening process, there has to be armed people that are part of this, because what if you do detect weapons, then what? If there's going to be a gunfight, you need people armed with guns in that situation. So I know of very few health systems in the country that do this effectively. Inova Health in Northern Virginia is one of them, but they screen everybody. It's actually more likely that members of your workforce would come in armed with a firearm than the public. So they screen everyone, including their employees, but I think it was 24.3 FTEs that they needed, new FTEs to operationalize it. So major cost and millions of dollars on the equipment. But they, full disclosure, they've seen their employee do you feel safe survey perceptions really skyrocket in a very favorable way, thanks largely to doing that. But most health systems can't do that. And there's always going to be backups too at your front end. If you do front end screening for weapons, there might be a line out the door and around the curb. And we manage our time so precisely in healthcare that we need our patients showing up to their appointments on time. So there's a practical reason a lot of hospitals end up not doing this. So they buy equipment and they stop the program, or they only screen for weapons at certain times of the day or certain entrances. If I'm a bad actor and you're only screening at one entrance, I'm going to go to a different entrance. We only screen during one set of times of the day, I'm going to come in at another time if I really want to do harm. So we have to have some common sense with this. And it looks, again, far more like the airport than some of the things you see out there, what I would call security theater, which is not effective weapons screening. I do think you can make a good argument as an element of your program, having metal and weapons detection screening at some special attention areas, your emergency department, your behavioral health setting. You're far more likely to see edge weapons. You don't have to be a resourceful person to get your hand on a kitchen knife. And there will be occasional flow of firearms. And a lot of the times, these things are on people's person for self-protection. They're not bringing it into weaponized, but it really adds risk when it's anywhere in your healthcare facility. So there's some great technology out there. A lot of the people that have done MRI metal screening over the years now have security products that are very discreet, and maybe you just do it in your emergency department, maybe you just do it in your behavioral health pod, but you're screening those individuals, that specific population, for weapons. But you also need to operationalize that equipment, have good policies and procedures, have well-trained people, and I often think you should have armed people if you're doing any type of weapons screening. Greater probability of weapons in the healthcare facility is stuff that's already there. Weapons of immediate means. And the greatest opportunity for harm is hands and feet. All over this country, every single day of the year, there'll be thousands of caregivers who are seriously harmed by hands and feet. And they had more active shooter training than they did bedside safety from hands and feet. That, to me, is the biggest tragedy right now of US healthcare. Yes, we need to do awareness and department level for active shooter. I get it. But we must invest more time in how to keep yourself safe, delivering bedside care to every population of risk behavior patient imaginable. These are often during restraint events or providing bedside care. So how do we keep ourselves safe from hands and feet, I think, needs to be our primary focus. Penalties, there's a big national push for felony penalties for those who assault caregivers, and I'm all for that, people. I've been advocating for that for 23 years that I've been in healthcare. But we have to be mindful of the fact that the justice system's out of our control, and having felony penalties might not have the prevention results that we expect. I've never found punishment to be the best pathway to prevention personally. But when we think critically of what are the populations of patients that are assaulting and injuring more caregivers than any other, and will penalties deter them and prevent violence? The number one population nationally, without question, that are assaulting and seriously injuring caregivers are the delirium dementia population. To no fault of their own, we know that because what's going on with their brain. They are not going to be charged with or convicted of a felony, nor should they be. The second highest volume patient population-wise, pediatric behavioral health patients. Not going to be charged with or convicted of a felony, nor should they be. And another big population that's doing so much of this violence, acutely psychotic adults. You can make an argument that they should be punished punitively for harming caregivers, but ultimately there are generations of legal precedent for not criminally responsible because of mental disease or defect. That is totally out of our control. That's on the justice system. So who's left over is really just a fraction of people that are harming caregivers. Could felonies make a difference for them? I'm not sure it'll lead to prevention, but maybe it'll lead to consequence. But ultimately, are our values to punish and people and have punitive action, or to care for them? So just something I wanted to put out there to think about. So ultimately, what's really causing all this bad behavior? I've been saying for many years, seldom, if ever, are we the cause of the bad behavior. It's directed at us as healthcare workers, and it can be terrible, but seldom, if ever, is it about us. And I was just at a class with a bunch of newly licensed nurses, and we came up with a list of what we call precipitating factors, those things underneath the surface that are really contributing to bad behavior. They're often unknown or unseen. Pretty heavy list that they came up with here. And I think a lot of us can relate to this, especially when we think about our friends and our family. Nobody's their best self when they're experiencing any of these factors, and usually compounding many of these factors on top of one another. So understanding the bad behavior is not about me, it's directed at me, but it's really more about these things. It helps my mindset. And the highest risk patients I've ever dealt with shared one thing in common. They were all survivors of early childhood trauma. Physical, emotional, sexual abuse as young children. I'm not saying that justifies their bad behavior towards caregivers, but it helps me understand it, and it very especially helps me not take it personally. All right, we really need healthcare to be a true judgment-free zone where we're not passing judgment on our people, that we're still trying to treat them with empathy. We treat everybody with dignity by showing them respect, regardless of how they treat us. Dr. Ruth Potee is an addiction specialist. I stole this from her with permission. Best presenter I've ever seen on any subject, but she talks a lot about opioid use disorders. And I'll read Dr. Potee's words. 2 people come to the ER. One had acute STEMI, the other an overdose. One gets brought to the cath lab, ICU, admitted for 5 to 7 days, brought to cardiac rehab, started on 4 medicine, social work consult. The other's given a dose of Narcan and kicked out the door. Are the 30, 60, and 90-day mortality rates higher for the OD than the acute MI? One might be 24 years old with 60 more years of life ahead of them. The other 84, completely different care. And I agree. That gentleman on the left, nobody's going to care that he's not taking his blood pressure meds, that he's eating red meat 7 days a week. He's going to get our best care without judgment always. But that young lady, oftentimes we let judgment creep in. And that's Dr. Potee's main message. But she does a wonderful job educating audiences on the permanent changes to the brain from substance use disorder, and the fact that this young lady's not popping pills, shooting up, get high party time. She's using not to be dope sick and not to deal with stress and often trauma. I've heard it said that substance use disorder is the scab that's trying to protect the trauma. And when people try to get clean, that is the equivalent of us tearing off our scabs. It gets pretty bloody, nasty, and messy, lot to deal with. So our skill sets, it really starts more importantly with our mindset, but skills, we need to put ourselves in the best position to do our best in the intensity of healthcare. So what can you do for yourself before work, during a high stress event, and after work to make sure you can deliver as your best self? You should spend a lot of attention on this with especially your clinical people, your bedside caregivers. What our patients and their family members have to say is so much more important than what we have to say. So tee them up. Hey, what's going on? How can I help? And then be that empathic audience. Everything here is important, but it starts with no judgment. I mentioned words matter. I gave you that frequent flyer example. Save that for the airlines, but be very intentional about how you communicate with people. That's relationship building instead of relationship damaging. Disruptive behavior we hate as caregivers, but we have to learn not to get into the power struggle, let it run its course, try to isolate the person. Hey, walk and talk, come to the private room. Let me get the person in charge to bring the temperature down. Impact the audience. Hey, folks, please go back in your rooms. You know, we're trying to help this person, give us some privacy, those type of things, but trust in your gut, moving away to safety if you feel like it's becoming an unsafe situation. I'm not going to go over this, but I teach an hour class on limit setting. Choose wisely what we have to insist upon, but be incredibly strategic in these moments. Be the person that just gives options. Put that patient in the driver's seat to be the decision maker. The more strategic we are in these moments, the better. And we know what people are going to refuse to do in our care. So let's put pen to paper, come up with a strategy, and let's practice it. What are the common refusals? Here's an emergency department example. What are potential reward systems we can lead out as a positive choice? What are we training our caregivers on for their personal protection at the bedside. Great concept of own the door, always have access to an escape route. How do you stand and position yourself? How do you manage your position, posture, and proximity at the bedside in a manner that can keep yourself safe? How do you activate an emergency response, but know there's going to be a gap of time before the help comes, especially in a rural environment where especially you're trying to activate law enforcement. I was told it could be an hour, 2 hours. Sometimes they'll never come because their resources are so lean in the community. So it's on your shoulders. So what does that response function look like? How do we activate it? But what can I do during that gap of time? Empower people, active defensive skills, applying run, hide, fight beyond just active shooter situations to any form of dangerous physical aggression. And when it comes to in-person training, this is where I'm at. Even if I can only have 30 minutes with caregivers, we're going to talk about protection at the bedside, and I'll send them an e-learning module on population-specific de-escalation. You've got to practice both to be effective in a high-stress situation. Some of these events happen right at the bedside, especially during restraints. Position, posture, proximity is so important. I've talked to 40-year caregivers, just nobody's ever talked to them about how to stand at a bedside. So often all over this country, brilliant people are bent right over at the waist over a bedside rail presenting targets. The best population about acquiring targets is delirium dementia. Pediatric behavioral health is really good too. So nobody's ever talked to them about approaching on an angle, standing with good balance, having your hands come up to protect your vulnerable targets, vital line guard, nose to belly button shaded away from the bedside. I don't want to get hit at all, but I can protect the outside where I most importantly disengage. Best way to keep yourself safe, don't be where the threat is. Not intuitive for healthcare workers, we rush in. So training them, empowering them, disengage, activated response, keep your distance till the help gets there. If we have to step in and control and restrain this aggressive person, what are our tactics to do that? Do we practice them? How can we stabilize somebody in a supine position? Right-sized teams, meaning not 10 people around the bedside, because then everybody's grabbing at something, effectively controlling nothing. Meanwhile, somebody's getting hit, punched, kicked, bitten, spit on, you name it, it's happening. So what's the right-sized team look like in your organization? Do you practice together? How do you put these restraints on? How do you remove them in a humane way? All over this country, restraints are removed one at a time, or take one arm out and one leg out. Are you kidding me? Talk about relationship damaging. Think about us. If you tied me up and you gave me a free hand, what am I going to do? I'm going to untie the rest of me. And we expect our behavioral health patients or those under the influence to be so disciplined that you give them a free hand. And if they try to remove their other restraints, you're going to punish them by putting back in. But again, this stuff persists to this day. So take them all off at once, or if you have to do stages, take the lowers out first and then remove the uppers after a short period of time. Restraints should be short duration interventions. Otherwise, they're very relationship damaging. And the key, practice, practice, practice. On the de-escalation side, super important as well, especially population specific. How I de-escalate an intoxicated adult male is far different than the skill sets I use with a child with autism. So providing this and being intentional about it. And when it comes to things like limit setting, doing some role plays, having people actually act it out really builds that confidence in a controlled environment, because we lose so much of our ability to think and act under high stress. The more practiced we are and strategic with our limit setting, you can really build that skill through effective role playing. This is the name of a presentation that I've incentivized here with continuing education for nurses and doctors, program called Strategy for Managing Encounters with Emotionally Confrontational Individuals, my favorite content to present. Administrative controls are also really important. Here's some stuff I'm excited about. This stuff can be a difference maker here. I especially like body-worn cameras. That is a real deterrent. Smile, you're on the camera. People do behave differently when they know they're being audio and video recorded. I'm a big fan of intelligence. It starts with your reporting and building your intelligence program. How can you be more proactive rather? There's things that are happening. Evidence-based violence assessment tools that can predict the likelihood of violence, and having behavioral emergency response teams, standardizing care, being consistent across all shifts if you have a patient with known risk behavior. We're trialing something here in my hospital called the Brosett Violence Checklist you might be familiar with, but This is a 6-point assessment that the primary nurse will do twice a day for patients. We're piloting that. If somebody scores out 3 or greater on their Brosett violence checklist, it's going to activate this BPA here that makes sure that security is contacted. Use a buddy system to enter the room. You consider a psychiatry consult. Those are violence prevention measures in the truest form. Engineering controls is also super important. The best way to keep yourself safe, not be where the threat is. Keep the threat out. Put barriers between our caregivers and the threat, particularly if they're doing documenting, they're going to be distracted. At-risk patients should not be able to access them. You do that for a vector of environmental design and controls. Access control, I'm a huge fan of. Videos primarily for investigations, but it also can be a deterrent. Duress alarms, I think we're way too dependent upon this. US healthcare, put a panic alarm everywhere, give everybody a panic alarm. Yes, it's critically important to activate a response, but it does not prevent any violence. It just assists with your response capability. But you have to empower people, push the button, but then what? What about that gap of time until the help comes? And the more you can integrate this technology, the more effective you'll be. And I'm a huge proponent of these sort of things. The push for anti-ligature really helps us keep safe as well while protecting patients. And really utilize this stuff. There's a great guideline from IHSS. Anytime you're doing any type of renovation, here's a restraint capable room, total safe room, and here's a patient and disposable paper scrubs. We're really doing a lot to protect him, but also protect us. So lastly, just some final thoughts for everybody. Kindergarten golden rule, but the underlying bolded point applies to us as caregivers. We have the vocation to make sure we uphold our values regardless of how people treat us, and we'll prevent a lot of violence in the process. We got to be the solution, not the justice system, nobody else. We have to choose our mindset during these encounters. Don't apply that reasonable person standard to folks who are struggling through the stress and unmet expectations of healthcare. Let's not judge anybody. Not everybody's going to cooperate, but let's bring the temperature down. Everybody gets there. Always be mindful of your stance and spacing. Be on your feet, be agile, be willing to adapt moment by moment. And that focus, like I said before, disengage, activate a response, put space between you and the person at risk is the best way to keep yourself safe. So that's what I had. If you haven't done so already, please make sure you mark your calendar for Friday, June 2nd, which is going to be the annual Hospital Against Violence campaign. I'll take my screen share down there. I think we only have a couple moments here, but is there any feedback or questions that I could address?
Yes, thank you. That was really excellent. And I do have a couple of things in chat. So going back to the beginning of the presentation in reference to the patient code of conduct signs, there was a comment in the chat that states the attorneys and local police say we need these signs so that the police can take action, for example, making an arrest. So you did touch on those signs assisting with the ability to punish, but can you maybe comment more on that for a moment?
Sure. Like I said, if you stand for these things, you have to communicate it to your intended audience at some level. But the list of thou shalt not and the zero tolerance type of messaging, I do not support. And again, ultimately, what police can arrest for and what they cannot is out of our control. And in most states, a state like Massachusetts, simple assault and battery is not an arrestable offense. So if the police come in, they cannot arrest. It's going to be a court summons and it's a misdemeanor charge. There are some other states, particularly that have passed legislation where that messaging is important, but ultimately it does go kind of case by case, particularly if there's a cognitive impairment or a lack of capacity.
Thank you. And then this was kind of maybe more of a comment, but going back to around the time of the effective weapons screening slide, there was a comment that said, what about not having drills and liability in reference to that as a hospital? I agree with his view, just have doubts about how he thinks about addressing the liability if we choose not to have an active drill.
You're covered through your awareness level training and your department level training, so long as it's documented. That's what's great about online learning management systems. For example, my health system of 40,000 people sends the same consistent training out to the entire workforce for annual education. And then we have that. We've provided that level. But I think we do people an incredible disservice by these full-scale exercises that are not lifelike, There's also those trauma residuals are real. They're happening all over the country for something that's such a low probability event. We empower our people more, from my perspective, with awareness and department level training. Run, hide, fight's not enough. If you don't talk about it in your workspace and apply it to where you work every day. And what we do is we track our documentation when we department level type of 5 to 10 minute drills is what I call them.
Thank you. And then lastly, are the behavior contracts signed only after an incident?
Yes, because they don't work in an acute environment where somebody's acutely psychotic or under the influence of a substance. It's when you've come down. It's post-incident. We bring the provider, security professional, the patient there. It's a great opportunity to reset expectations that we all agree to continue your care. Because ultimately, if we rush towards terminating patients, sometimes we are greatly increasing the likelihood for targeted violence towards our caregivers. It's that act of termination that often sets people off. So they'd rather have a very difficult conversation and have to agree to this set of behavioral expectations. In my experience, I've done tons of these. And oftentimes we can continue with a more healthy relationship.
Thank you. And those are the only questions. So we still have quite a few people on, even though we're about a minute over. So if you do have a question, feel free to unmute or drop something into the chat. But Brendan, there are several comments that it was a fabulous presentation, awesome presentation, terrific information. So thank you. We appreciate it. I don't see anything else coming into the chat. So I think we'll go
I
ahead.
have one question for
Yeah.
a hospital that I'm working with. They're not Joint Commission accredited. You spoke to Joint Commission accreditation and following those policies. I believe they're DMV accredited. Are there major differences between the policies required for workplace violence programs?
No, a DMV shop, and I network with a lot of them. They really go towards OSHA guidance. So they're going to take a look at that 3148 and they're going to look at OSHA standards, which if some of the current pending legislation passes in the future sessions of Congress, they'll absolutely apply the same type of standards. They're going to want to see that you have a workplace violence prevention program. And if OSHA takes effect, that's when they can take punitive actions against your hospital for violating those standards. But for any accreditor, there's going to be a lot of correlation for what Joint Commissions already put out there. Nobody's looking to reinvent the wheel.
Okay, thank you.
You're welcome.
Thanks. Okay, last call for a question. If you do think of something after we dismiss, then please don't hesitate to contact someone at CORE, and we would be happy to pass your question along and get a response for you. But we thank you for your time. A huge thank you to you, Brendan. It's been fantastic having you on and sharing this important information. And we will see you guys next month. Thanks so much. Bye, everyone.
Thanks, Cassidy. Thank you, everyone. Be safe. And Cassie, I'll just share, if you have a mechanism of sharing my email contact with